So the outline or the goals are, we want you to have a basic understanding of like the physics of how the image is made, the basic physical principles. For this 280A, we're going to focus on computed tomography, a bit of X-ray imaging, computed tomography, and MRI. Those will be the principal examples we're using. And we'll go into some detail on those modalities. We're leaving ultrasound and nuclear medicine and PET scanning and things like that for 280B. Okay. We'd like you to understand those parameters that define, say, a good image from a poor image. And so what does that even mean? Like, what is a good image and a poor image? Well, when you're using your phone to take pictures, you're quite familiar when you get a poor image. It may be the contrast isn't high enough, the signal to noise is really low because it was a birthday party and there was only one candle or something, right? So those, we're going to quantify what that means. Most of you right now have in your pocket an amazing imaging device that produces like a 4K by 3K pixel image at just, instant, right? And you just like develop gigabytes of these images. And so we're all taking images all the time. X-ray, CT, and MRI take similar pictures. They're digital pictures. They're usually about half a K by half a K, like 512 by 512 is a common dimension, or in MRI, even 256 by 256. So they're quite small compared to the image you get on your camera, like on your phone, which makes them easier to like work with on a computer. But oftentimes they're three-dimensional. So the other thing we want to be able to engender is some common sense about medical imaging. So if you see something in a medical image, that you should be able to look at it and say, is that actually really happening? Or is that some artifact? Is that truly a lesion in this patient, or is it something else that has caused this signal that is, an error, basically, in the imaging system? Imaging is really important to medicine. Virtually every patient that goes into a hospital now gets some kind of imaging done when they come through the door or shortly thereafter. And for very good reason, because you can see what's going on. I mean, if you don't know what's going on, oftentimes you can just look, right, by doing a CT or doing an MR or doing a chest film or something like that. And so it's done over and over and over, like 100 million times a year people get CT scans, literally, right? So the basic setup is you have an object. In this case, let's say the true object is a person's head. And this cartoon is basically showing us what that true object is. Hopefully. So here's our true object. Our imaging device measures something about that true object. In X-ray, it measures the attenuation of X-rays that you shoot through the object. You shine them through and look at the shadow. In MR, we're going to actually create signal from the object. Turns out from the protons in the object, we're going to get radio signals out and make a picture of that. And so that's the imaging device. It causes that signal that we measure. And so we have raw data that we've measured after putting the patient in that device. In MR, this raw data, it's very easy to describe. It turns out it's the Fourier transform of the object. In CT, it's attenuation, X-ray attenuations in space from the object. These raw data are then passed through a reconstruction algorithm, and reconstruction algorithms run the gamut. I mean, there's simple reconstruction algorithms, which are just straight up Fourier transforms of the raw data, all the way out to deep learning systems that take input of raw data of 10,000 images, and you know what the appropriate output is, and you basically teach this deep learning filter / algorithm on how to produce these pictures, which gives you a whole bunch of mysteries along the way. So we'll look at a number of these reconstruction algorithms, the ones that we can write down analytically, and then how you approximate the analytical solution with some kind of computer-generated solution in order to produce an image. And the image is a very simple thing. It's an array of pixels. As I said, they're 256 by 256 or 512 by 512. And at each point, at each pixel, you'll have a brightness, right, or a signal value. And in the old days, when I used to do this back in the 80s, in the early 80s, those pixel brightness values could be anywhere from, say, 0 to 256, right? So 8 bits. Now, you basically can have a 16-bit pixel brightness. So it's quite a high dynamic range of values can be inside one pixel. And that's what the picture is, right? Is that set of values. You can obviously have it in a third dimension in Z, right? And then sometimes each one of those pixels can actually be a vector of numbers, right? So as opposed to just a simple scalar value. But that's the basics of an imaging system. Medical imaging started at the end of the 19th century when Röntgen, he discovered X-rays, and then he shortly thereafter discovered that you could make a picture. You could if you had an X-ray source and you had a film over here, a scintillator over here, you could actually make a picture of an object because you were kind of translucent to X-rays. And he made a very famous picture of Anna, his wife's hand, right? She had a ring on, and that's like the first medical X-ray, or the first human X-ray, is Frau Röntgen's hand, right? And he actually published that. And by 1897, I think there was like 28 papers on X-ray imaging already, right? So it was back then there was already this like drive, as soon as something was discovered, you publish or perish. They were printing out these papers. And before the turn of the 19th century, there were medical devices. And Johns Hopkins got one of the first ones. And so at that time, it just took off. So medical imaging took off. In physics labs at Stanford and Harvard, independently, Bloch and Purcell discovered nuclear magnetic resonance. And this was in a physics environment where they discovered this signal that came from a nucleus when it was put in a magnetic field. You could actually stimulate a radio emission from the nucleus when it was in this magnetic field. They received, I think, a Nobel Prize for that, for the discovery of NMR. And then later, about, say, 30 years later, people started thinking about and making NMR imaging devices. So using that signal to actually image inside the body. So Lauterbur was one of the first to do that. Hounsfield, at the same time, he was working at EMI, designed probably the first diagnostic X-ray CT scanner in which he imaged the brain by taking an X-ray source and rastering it across in a line, and then changing the angle and rastering it across again, and then making a two-dimensional picture from that. And this was the company that at the time they had a lot of cash at this time because the Beatles had just broken up, but they'd made them a lot of money before they broke up, right? So EMI actually owned Capitol Records, which probably funded his work. And then, in the mid-'70s, people were building whole-body CT scanners. So here's this famous picture of Frau Röntgen's hand, right, with a big old ring on it. Obviously, not terribly high resolution because the X-ray source itself was quite broad, and probably the detector itself wasn't terribly high resolution. But he won the first Nobel Prize in physics, apparently, for this. So the very basic X-ray imaging is quite simple. If I have a X-ray source here, which is like a sophisticated light bulb, it's essentially a light bulb, but it emits X-rays. Right? So the X-rays come out. You collimate those X-rays, so you put, say, a lead shield around it except for a hole, and then the X-rays just come out in one direction, right? And then, so that's on this side of the room. And then on this side of the room, you have a detector for X-rays. And so it could be a scintillator such that when an X-ray hits the scintillator, it gives off a flash of light, and then you record that on a film, photographic film. That's the way X-ray imaging was done for decades and decades, right? And all you do is put somebody in front of that, and they cast a shadow, right? So it's like you're just shining an X-ray source through that patient, and they cast a shadow. That is called right there is a chest X-ray, and I actually don't know how many chest X-rays are done, but it's probably close to 500 million or something have been performed, and it gives you a really nice picture of what's going on in that patient's lungs. You get basically a profile of the heart, etc. So that's the simplest form of medical imaging. Basically, is this is shining X-rays through a person. Where there is a lot of tissue or there's bone, those X-rays will get absorbed by the person and they will cast a shadow, and that's what you see. So X-ray imaging went through a fantastic evolution. Here's a very early medical X-ray system. Here's the source. We've got all these high voltages making electrons hit targets and making X-rays here with the source. The patient, poor devil, has to actually hold the detector himself, like standing on like that. He's holding the detector, but it's nice because it's really close to him, so you're not going to get a lot of blurring magnification. So that's a very early system. And then, of course, Philips, the companies that make these are people like Siemens, Philips, GE, light bulb companies. It's not surprising. Or they used to be light bulb companies. They all got out of light bulbs when the LEDs hit the street. But Philips, this is, I think, from the 40s or the 50s. I don't even know if there's a date on here. But shoe stores had this wonderful product where when you tried on a pair of shoes, you could slip your feet into this shoe fitter, and then you would look down a scope and look at your toes and your feet with X-rays. Right? So you're looking, you can wiggle your toes. And my first year physics prof at University of Toronto actually used one of these when he was a kid. And so you wiggle your toes, they fit just great. So there's a great product that turns out to be not so great in the long run because you don't really want to expose yourself to a lot of X-rays over the course of your life, right? A few, when they are well warranted, is a good idea. Just doing it all the time or any time is not a good idea because it turns out that X-rays ionize molecules, and so you get all these free electrons going around and damaging tissue, and particularly they can damage DNA. And if the repair doesn't go right, you can get long-term consequences from that. So ionizing radiation, not so great. However, we are all exposed to ionizing radiation all the time. Right? So when you walk outside, just coming from the sun, cosmic rays, and also from the concrete in your basement, radon produces high energy photons that you're exposed to. And the baseline level of your exposure is about 3 millisieverts a year just by being alive, right? And so now most X-ray CT images can be done for around 1 millisievert or less than that radiation dose. A modern X-ray system that is just a projection system looks something like this in some contexts. There's a source here, a detector behind this guy. He's going to drink this solution while being imaged, right? And so the solution is like a milkshake. It's really thick, viscous stuff. And you drink it, and in that milkshake is barium. And barium absorbs X-rays a lot, so you get this shadow of the barium being swallowed. And so you can see the esophagus. And so if you have trouble swallowing and you want to identify where that trouble is, you can actually dynamically watch this being swallowed. Or if you have some kind of lesion or bump in there, you'll see it on this. It's called a barium swallow. Doesn't taste great, but it's not terrible. So here's a chest X-ray. Again, source, shine it through the patient. The patient absorbs the X-rays. So here's the patient's spine. Turns out bone absorbs X-rays much more readily than soft tissue like muscle or liver. And so you see ribs, you see the spine. This is the heart, this profile here. And this cloudy thing right here is a classic sign of pneumonia. And so you have a high density fluid in your lung. And so you can diagnose somebody who has some lung abnormality really quickly with a quick chest x-ray. This is x-rays used to image the human breast. And you get a pretty complicated pattern of absorption of x-rays when you shine x-rays through a breast. And usually you compress the breast, try and make it as two-dimensional as possible. And then you shine x-rays through. And then you expert viewer looks at this to discover a cancer. Right? This is one of the most common forms of cancer, particularly in younger women. And those of you who have experience reading mammography can see the cancer. Right? Anybody see it? No, it's tough. It's there, but this is a tough read. And so this is one of the reasons why you want to push image quality further and further and further, is because these poor devils are trying to read this and find a tumor here, right? And it's not easy. And so expert systems are being trained to, like deep learning systems are being trained to take 1 million of these, and you know the truth because you know the history of the woman and whether or not they did actually have a cancer. So you actually have truth data, and make a machine that could read this thing. Because humans are okay, but not perfect. But our job as engineers is to make these pictures better and better and better in the sense that the cancer will stand out. The contrast between the cancer and the background will get higher so that a child could read it. But that's not the case right now for mammography. This is, what do I do? Arrow, I think. So this is an X-ray picture through a patient who's lying on a table, and it's a picture just through their heart. Your heart is right here. You can't see it right now, right? And this device here is a catheter that's been threaded up their artery, their femoral artery, and around their aortic arch, and then brought down to their heart, and then plugged into their coronary artery. It's a plastic catheter, and you just like feed it up there, shuffle around a bit, go, okay, I'm in, all right? And so you've got that thing engaged in their coronary artery. And then you just push contrast into that vessel, right? Which it's a daring thing to do, but it's done about 1 million times a year, literally. And so that is called a coronary angiogram. And so when you push that contrast into the vessel, right, the contrast itself has iodine in it, which absorbs X-rays very well, and so casts a very good shadow. And so now it's quite trivial to see where those vessels are, right, after you've pushed that contrast agent in. Before that, you had no idea where they were, okay? So this is the combination of X-rays plus a contrast agent to produce a really high contrast to noise picture of the underlying vessels, right? And what you look for in those vessels is a region in which the vessel gets really narrow and then comes back to normal diameter. And that region is something that you can go in and treat if the person is having chest pain and difficulties with perfusing their heart. The reason these pictures look really clear is that the detector itself is a high-resolution detector. The X-ray source itself is a very high-resolution source. The X-rays are coming from literally basically a tiny little spot and shining through the patient, and they're being strobed so that the exposure for each frame of that movie is only 50 microseconds or something. So they're really fast pictures. The shutter speed is very, very fast. And so you get nice, clear pictures. And this technology has been developed over the last 80 years, and it just gets better and better and better. So computed tomography, sort of outline sketch of the history of this, Johann Radon mathematically discovered that if you know projections through a 2D object, if you know just line integrals through that object in a whole bunch of directions around the object, that you can actually reconstruct what the object is. You can reconstruct in detail what the object is. Mathematically, he showed that, Alan Cormack also showed this with the anticipation that you'd be able to do it with X-rays in medical imaging. And he published his work in 1963 in Physical Review or something. It was a physics journal. It's a really interesting read. You just Google it and download the paper. So it's a ton of math, and it all works. It's great. It's like modern CT imaging, just there in 1963. And there's like 4 citations, and he's the only author. That's the way publishing used to be. So nowadays there's like 900 citations and 18 authors. But and then Hounsfield independently built this two-dimensional CT imaging system. And then the 2 of them received the Nobel Prize in '79. So CT, really, really quickly, if I have an object, so here's a 2-dimensional object, I have a background and 2 smaller circles that actually cast a bigger shadow or attenuate X-rays more than their surroundings. If I shoot X-rays through the top down towards the bottom, I can plot how many X-rays I measure, and so I get a high number out here. This little object causes an attenuation or fewer X-rays to be measured here. This object, because it's thicker, actually gives us even fewer X-rays across there. This diagram actually isn't that correct, but anyway, it's out of Sproul's book. But this profile, if I now call this a brightness or a height and I project it back, I get something that looks like this. I just project it back onto the whole space, and I do that same experiment 90 degrees, and I project that back. I get a very rudimentary picture of where those 2 larger attenuators are, right? Just in 2 dimensions, right? And so at least I know there's some different attenuators in there, and I know kind of where they are in X and Y. So you can imagine if we do this with 256 views, I should be able to reproduce a better representation of that object. And we're going to do this in detail and do all the math behind that. So how do you measure those projections? So if I'm shooting X-rays through an object like this and I want to measure like how many X-rays get through and are absorbed by my detector, the geometry of a detector looks something like this. In the early days, the detector could be a straight line, of individual X-ray detectors, and I could move my source across, and if my object is here, I could measure that. Another option is I have a single source that gives me a fan beam of X-rays, and my detector is sitting across here, and so simultaneously I can just take one shot and measure across the detector how many X-rays get through. So if I put an object here, I cast a shadow on this detector, and I can measure the relative amounts of X-rays. And now the modern CT scanner actually has not only detectors in this direction, but it also has multiple slices, right, simultaneously being acquired. And so a modern CT imaging system would have about 1,000 detectors in this direction and upwards of 256. The most common is 64 in this dimension, but now you can get them 256, 320. So you're basically getting volume pictures, right, and looking at different angles through the object. The basics of how a computed tomography system looks is you have an X-ray source here, right, and it projects, the X-rays in a fan beam. I have my detector here, and the whole thing is going to it's rotating in this direction around the patient. And I'll just take different views through the patient as this system rotates. And so that relative position of the source, the X-ray source, and the detector stays constant, the relative position, and they just both rotate together around the patient. If I rotate that constantly here, I can take the patient and just, basically drive them through the system while that thing is rotating constantly. And that gives me information in both the theta direction here and the z direction as I'm going through. That's called spiral scanning. The big delta in X-ray or in CT technology, one of the big deltas occurred when, instead of having a system where you say I start my detector here, I rotate it once and stop, because I have cables, right? I have a whole bunch of signals coming from this detector, and they're coming out on cables. And so I have to rotate the thing once, stop, then rotate it back, because you can't like tear the cables up, right? The big jump in technology, Siemens did this first in like the mid-'80s or something. They, instead of having those cables, they put basically a set of contacts on a slip ring. And so those contacts were like brushes sitting on the side, and then they could just keep rotating the thing, and all of the signal came out on these brushes on the slip ring. So you could rotate in one dimension, just keep it rotating. And so at that point you say, well, let's just rotate it faster. So they just kept rotating it faster and faster and faster until finally the thing's just really spinning fast, right? And so you're getting pictures very quickly. Granted, you have to make more X-rays per unit time for that to occur, right? Because basically you run out of X-rays if you go faster and faster and faster. So you need a more powerful tube. And then as that thing rotates faster, then you just push the patient through faster, and you get the whole data set in seconds, whereas it used to take minutes. So that was the first huge jump in CT technology, was going from 20 seconds to make an image to 1 second to make an image. Now we can make an image in 140 milliseconds. Right? So this is what, if we look back at, let's take a look at this geometry of detector. Okay, and we're going to put a person in here. Our X-ray source is here. Person is sitting in here, and we're going to spin this thing around the person. Right? If you can't spin this thing around the person, what else could you do? Spin the person. Right? So if you had a detector and a source here, and you're stuck, you can't spin them because you're not a smart enough engineer to figure out how to spin the whole damn thing. You just put the patient there and like spin the patient, right? And then you get all the views through the patient. Uncomfortable for the patient. However, high resolution CT images of like animals, like and objects are usually done that way. You usually put it on a gantry here, or on a gimbal system, and you have a source here, and you project the picture onto a detector over there, and then you spin the object. And the big advantage to that too is you can put the source close to the object, right, and then project it into a huge detector, right? So you can magnify it if you put the detector back here, right? So if you're imaging mice, you can put the mouse here, detector here, or the source here, mouse here, and then your detector way back there. You go, big mouse on the screen. This is what a person looks like when you take these individual X-ray projections in 2 dimensions, and the gantry is spinning around the person. We're not spinning the person. They're lying on their back comfortably. And all we're doing is we're taking different looks at the person as we rotate both the source and the detector around, right? There's 256 detectors this way. There's about 1,000 this way. And there you get that whole set of essentially really short chest X-rays from different angles. And then the reconstruction problem is, okay, I've got all of these projections. How do I now make a 3-dimensional representation of the patient from these data? They're all these projections, right? So the essential thing to understand is that, let's just stop, oops. If we stop this in one point, the brightness here corresponds to the amount of attenuation. So it's not actually an X-ray image in the sense that a dark shadow corresponds to attenuation. It's been inverted. So brightness means I've got a lot of attenuation. At any one point on this detector, the attenuation that I've measured there, the relative attenuation, is from the line integral through the object in this direction. So all of the tissue along the line from the source to this detector, all that tissue has had a chance to absorb X-rays. So you have to know it's the sum of all those absorptions along that line that I'm measuring in this single projection. So that's what I got. You just write it out, and it's the sum of all those absorptions, right? And that's true of every position. We click the rotation, and we take another set of sums through each projection angle, and that's more data. And this is when you go back to the radon transform, mathematically, radon showed that if you have all of those sums, you can actually reconstruct the object from all those sums. In the early days of CT, so here we are in 1975, and so now Siemens has produced a clinical scanner, right? And most of the early clinical scanners were head scanners because they, it's a sort of manageable size. And you get a 128 by 128 pixel image, looks something like this, and it would have taken like 20 minutes to make that picture because they had an array of detectors and they would raster a source across and then click the angle of the whole thing and do that procedure again and use that data to reconstruct a 2D picture. So that was 20 minutes, you get 128 by 128. This is a modern day Siemens scanner. This could be from right now over in the hospital. And you can see the image quality is much better, right? You have much better spatial resolution and much better signal to noise. You can see soft tissue structures that you could not really see here other than the ventricles in the brain. And this picture is 512 by 512 and is probably taken in about, 200 milliseconds or something like that. The whole thing, around 200 milliseconds. So we've come a long way in CT imaging, and that's why this is used a lot. So here's the early scanner where you had the patient's head in here. This is a modern day scanner. Looks basically the same, just a little bit bigger. You can fit the whole patient in there. Just a lot better engineering. And pretty remarkable stuff can be done on these scanners. So somebody comes in, this is a young woman, she's in her 20s, acute chest pain, sudden onset acute chest pain. It's like, what's going on, right? Acute chest pain can be about 50 different things, right? So it's really hard to know, like, is it just indigestion? Is it a heart attack? Is it, in this case, this woman has an aortic dissection, right? Which is a great thing to discover while you're still alive, right? Because you're not going to be alive for much longer, right? So basically, this whole image here was done just the way we said. Detector and source start spinning. The woman is just put through there in about 2 seconds, like from her pelvis up to here, and then a contrast is injected into her veins so that you can look at the vessels. And her aorta is this object here. It goes into the femoral arteries down here. And if we look at it from the side, that structure right there down the middle of the aorta, that is not supposed to be there. That is part of the lining of the aorta has peeled off and is sitting in the middle of the aorta. And it's called a dissection. And so you have to go in there and surgically repair that, or at least put some kind of graft down there to keep the aorta open, right? And then you're fine, You're not fine, but you're alive. You're going to live for another 50 years or something with that. So in terms of trauma and emergency medicine, CT is hard to beat. Right? It's very fast. You can come in with like lines everywhere, EKGs on you, just in a crash scene, and you can go in the CT and get imaged. There isn't a heck of a lot to prevent you from having that happen. So there's just in your slides, you'll see here's some of the details. They don't mean anything to you now, but by the end of this section of the course, you'll come back and look at these numbers and you'll see how they did this scan. Because there's many ways to do scans. This is the increase in usage of CT I think this data is from the ER. Yeah, emergency department visits. Percentage of patients who go to the emergency department that get a CT scan has increased. This is from 95 to 2007. All right, so this data is 12 years old. And number of visits with CT in millions. So we got 16 million, right, CT scans just done in the ED, like the emergency department, right? So it's a huge usage of this technology, and specifically in older people, right, where you don't have any concern about radiation really. Younger people, you want to, you do have some concern if somebody is 18 or younger. If you heavily irradiate them, then they carry that risk of a mutation for much longer, and so it can actually express itself over the course of their life. If I'm 68 and I have chest pain, I really don't give a damn how much you radiate me, to tell you the truth. Just find out what's wrong, right? If you're a kid, it's a different story because you've got a much longer window, right? So here's a CT scan of a heart. This entire volume is done in 150 milliseconds, right? And you get this 3D picture of the heart. And this is a coronary vessel coming down basically along the front side of the heart. It's called the left anterior descending coronary vessel. This is the circumflex that goes around the back of the heart, and this is the right coronary artery here. And this whole 3D volume was acquired in about 140 milliseconds, right? And so for people where you're trying to diagnose whether or not they have heart disease, i.e. they have a lesion in their coronary artery causing them chest pain, this is a really good way to make that diagnosis. Specifically, it is a really good way to rule out coronary artery disease, because if all of these vessels are open, there's a 99.5% chance that they are negative. They don't have coronary disease, right? So that's what it's really good at, is eliminating the possibility. There are ways to produce signals that look like lesions that actually aren't serious lesions. And so you can get false positives, right? But you rarely get a false negative. We'll look at that whole concept of what it means to have a false positive, false negative, sensitivity to disease versus specificity of your diagnosis. And I just listed some. I would strongly encourage you to go to all of the big company sites. Actually, Toshiba doesn't exist in CT anymore. It's Canon now. They got bought. But just go to the commercial sites and look at their best pictures. It's phenomenal data that's out there. So MRI, these two guys discovered NMR in their respective physics labs in '46, and then there's a whole, you could think of, there's a controversy as to who was the first to do NMR imaging, but Paul Lauterbur and Peter Mansfield got the Nobel Prize for it, and were one of three folks who made the first pictures. Paul Lauterbur made a picture of two test tubes in his NMR spectrometer, right? Which is like it's generally thought to be the first NMR image, right? Are these two test tubes sitting beside this? And when you get into NMR, you'll see, the principle of how this works. My feeling is that those of you who know anything about NMR, he might have not been good at shimming his magnet, and then got way off on his shim so that the magnetic field is really non-uniform, and looked at it and goes, hey, that's a projection of those test tubes. I could image with this thing. But I could be wrong. This guy, it turns out, if you want to know about electricity and magnetism, this is a complete aside. It turns out I have read this book cover to cover because it was my second-year physics textbook. It's amazing. It is an awesome textbook for electricity and magnetism. And Purcell wrote it, and it's terrific. So I would highly recommend it if you want to know about E&M. So this is Raymond Damadian, who had the idea of T1, T2 relaxation times highlighting cancers, and thought that it would be a good idea to put people in magnets and try and measure T1 and T2 but couldn't really figure out a good way to do that. He figured out a bad way to do it and built that system. This is Bill Edelstein, who has one of the first whole body systems at Aberdeen in Scotland when he was a grad student and postdoc there. And then this guy, Peter Mansfield at Nottingham in England, also made a whole body functional NMR imaging system in the early 80s. And so he shared the Nobel Prize with Lauterbur. This is what a new, fangled NMR system looks like. It has a very large cylindrical tube, and inside, the primary thing inside that cylindrical tube that makes this work are coils that have superconducting current running in them. And the current is so high that it produces a very large magnetic field, like 50,000 times the Earth's field, things like that. And so with that high magnetic field, you can get a really high amplitude NMR signal from a person, right? And using that high amplitude NMR signal, you can make pictures with it. There are gradient coils associated with temporally changing the magnetic field over space in X, Y, and Z. And so when you switch those gradient coils, you can then encode where the signal is coming from. And so that's the basic unit. My PhD advisor got into NMR a bit late in the game. I think he got in about like 83, maybe 82, because he was doing high energy physics proton therapy at the time. And on the back of an envelope calculation for NMR imaging in the late 70s, he figured out that you would need a magnet the size of a truck, and it would cost like $1 million. So nobody was going to do this. But of course they did it, right? And they wound up with magnets the size of a truck, and they cost $2 million. So it's a pretty sizable piece of equipment, but I think the big jump in making NMR images in people was the commitment of companies to build these magnets initially. Right? And that goes on. The race to build the bigger magnets still is on. And here's you can buy this one just in a box, and they'll deliver it and put it up for you. You just got to give them the $2 million and press go, and it works. It's great. So that's a clinical system. And then there are more experimental systems in which, this 11.7 T neurospin, so it's like 4 times the magnetic field of this one that comes out of the box, generating a much higher amplitude signal, right? But it also comes with some technical challenges. But I think Dr. Liu will talk more about that. 7T magnets are now fairly common. You can also buy these off the shelf from almost any manufacturer now as a 7T system. And absolutely spectacular pictures come out of these machines. These are images of the brain, same slice through the brain, just changing the timing of how the signal was elicited from the patient, right? If you get signal in rapid succession, and make a picture from that, you can weight it with the T1 contrast. If you let everything come back to relaxation and you image, with very slow repetition, you can get a picture that's just density, like water density, and then here's a T2 weighted signal that tells you whether or not how long the signal lasts in time after you generate the signal. And so all of these signals are kind of dependent on what type of soft tissue you're imaging, right? And so you get soft tissue contrast, whereas liver, heart, muscle, brain kind of attenuates X-rays the same, right? Very, very much the same. Whereas in NMR, those tissues can engender much different signal intensities. Okay? So you get these ridiculously beautiful pictures. In the same way, you can highlight using either a contrast agent that you inject into the patient, or using the fact that blood itself is flowing, you can generate contrast from that mechanism, or that it's it's flowing from a distant place into the place you're imaging. It will generate contrast. And so you get these really nice angiograms. And probably the best recommendation about angiography and MR is that you can actually do really good angiography without injecting a contrast agent. So you can just put the patient in and do this angiogram with no contrast agent. And so these are very fine vessels in the brain using a MR scanner. This is some of the best brain imagers in the world are here. And they've been doing remarkable things looking at perfusion of tissue, looking at perfusion during function, during resting state, and things like that. And so here's some slides from Eric Wong, who works with Tom, where you have the anatomical slices of the brain, and then the brightness of the signal in these pictures is entirely proportional to how much blood has flowed into this slice over the time that you're imaging or the time you're evolving the signal. So you can get a perfusion-based image sort of in millimeters per gram per minute of tissue, right? It's like quantitative perfusion of how much blood is going to that region. And so if somebody, obviously if they have a stroke or something like that, you can see that. But also, if they're thinking about something that causes one area of their brain to be more active than another, that will actually cause an uptick in the perfusion in that area. You can, with MR, gate your data acquisition to the ECG of the patient. And let's say over 16 heartbeats, I take, 20 different acquisitions in each heartbeat. So I take data in 20 different boxes on each heartbeat, right? So inside each one of those boxes now, over that 16 heartbeats, I've got enough raw data to make a picture of that section of the heartbeat in time, right? And then when you play those back, those 20 images, you get something that looks like this, right? And so you get, granted it's retrospectively reconstructed. It is a movie of one heartbeat, but it took 16 heartbeats to get it. So it's not real time the way echocardiography is, for example. But if those 16 heartbeats are the same, and remarkably, most of the time each heartbeat is quite similar to the one preceding and the next one, you can get really pretty pictures of these movies and decide whether or not the person has normal cardiac function. All hell breaks loose when the person has sort of an irregular heartbeat. So let's say they're in atrial fibrillation, and so the heartbeats are coming at sort of random intervals. Then it's much harder to make one of these movies. And that's the kind of Achilles heel of cardiac MRI. It's the fact that irregular heartbeats really cause you trouble. But you can get a plane in any orientation through the heart. So this plane here, let me play this again. This is called a short axis view. And my heart would look something like this. So I gotta stay here for the microphone. My heart looks something like this. A short axis view cuts it this way. So it looks like a donut in the view. And so this is the left ventricle ejecting blood out the aorta. This is the right ventricle injecting blood out the pulmonary artery to the lungs. Right? Chest wall. The white stuff here is fat. This is fat. And this is liver. And then you can reorient your imaging slice to any arbitrary angle that you want. So you can get any arbitrary view of the heart, like through a specific valve, through the apex of the heart, or etc. And so here now the right ventricle is up here. This is the left ventricle ejecting out. You don't see the aorta in this view, but you do see the left atrium. Blood is coming from the lungs back into the left ventricle. This is the right atrium. And it's very useful for imaging cardiac function if you're not in atrial fibrillation. Another thing that I just touched upon earlier is that if you image with specific timing with the MR imaging system and blood flow changes dynamically to different parts of the brain, you will see signal go up and down, depending on the blood flow. Right? And if you have somebody in a magnet and you're just imaging continuously and you do some activity, like you say, recognize, is this a dog or a person, dog or a person, dog or a person, or you make them tap their finger, something like that. And so tapping their finger, this is a classic one. It's the first one we did when we read the first paper. Got in a magnet and did this. You just tap your finger, and then an area of your motor cortex will actually light up corresponding to that motion. And it's called functional MR, and it has been with us for, I guess, 25 years or something now, and has made huge strides in measuring cognitive function, in people doing various tasks. It's really interesting. In fact, they used fMRI to show there was a woman, she was like the 5th best chess player in the world or something, and they presented her with not random, but chess positions, right? So they had a chessboard and they would present one and then let it go and then put another one up and let it go. And some of them were games in which she'd won and so she'd recognize them, etc. And it turned out the area in her brain that lit up super bright was the area for recognizing faces. So it's like she recognizes and goes, "Oh, that's bad," So she co-opted that area or something of her brain to kind of immediately recognize whether or not this position was good or bad. I don't know if any of you played chess, but some people are born with like chess vision, like little kids. They walk up. My son used to play chess, and I would go to these camps. And 7-year-olds, I'd play 7-year-olds, and they'd like scoot up to the table and look at it and go bang, and then run away, right? And then I'd be sitting there going, oh, and I'd take a minute, I'd make a move, and then the kid would come back looking and go bang, and then run away. It's like they just look at it and go, no, I know what the next thing is. I have no explanation for that. And so this is another thing you can do with MR, which is really cool, is you can map the underlying structure inside cells of how water diffuses. So if I have a cell that's sort of a cylindrical shape, like a neuron or a muscle cell, something like that, so it's kind of cylindrical, it has walls, and then there's a preferential direction for water to diffuse in that environment. And that is along the cell. It's easier for water to move up and down that way than it is to go through the wall of the cell. If you make that measurement, that perfusion direction, and then you make a map of that in the brain, it comes out looking like this, right? And so this is essentially the structure, the physical underlying structure of how the neurons are intertwined together. It's like the human connectome. So, and that's called diffusion MR. And there's a really cool paper by Steskel and Tanner in the 60s, so this is before MR imaging, in which they talked about diffusion MR of samples in test tubes, right? And so they have a substance, you can measure its diffusion constant by its MR properties. And they wrote out the signal equations and how they made these measurements. And it involves switching gradients off and on when you're measuring the signal. And if you look at the equations in their paper, MR imaging is right there. It's right in front of them, right? This is 10 years before Lauterbur made his picture, right? But you go back to it and you go, oh, that's imaging, right? It just went right by.